Case description. A 70-year-old male patient presented with a chief complaint of ill-fitting maxillary denture since about 6 months. The patient had undergone extraction of all his teeth due to mobility and decay and had been wearing the denture since about 4 years. The patient was medically fit and did not suffer from any systemic illness. On examination, well-preserved maxillary and mandibular alveolar. The following photograph is a clinical presentation of the patient. Indicated by an arrow is an incidental finding of a well-defined, sessile, slightly yellowish elevated nodule, noted on the left side of the hard palate close to the midline, measuring 2 by 3 mm in size, and being covered with intact mucosa. On palpation, it was non-tender and firm. The patient was unaware of its presence. It was totally asymptomatic. Differential diagnosis. Clinical differentials may include the most common lesions, such as fibroma, the most common benign neoplasm of the oral cavity, and are composed of fibrous or connective tissue. These lesions are mostly sessile or slightly pedunculated with a smooth contour, pale pink color, or may look dark in color. They have firm consistency and occur on gingiva, tongue, buccal mucosa, and palate. Fibroma are hyperplasia of fibrous connective tissue in response to local irritation or trauma. The diagnosis of these lesions is based mainly on histopathological features, because most of these lesions are relatively characteristic in their presentation. Neurofibroma. They are benign tumors arising from peripheral nerves, usually present as non-tender discrete masses that range in size from a few millimeters to several centimeters. The lesions are typically pedunculated or sessile, usually painless, but occasionally pain or paresthesia is reported due to nerve compression. Tongue, buccal mucosa, and vestibular area are common sites, and posterior mandible is the most common intraosseous location. Histopathological diagnosis will show peripheral nerve tissue and dilated blood capillaries. Minor salivary gland tumors. The palate is the most frequent site for minor gland tumors. Pleomorphic adenoma is the most common benign tumor, while adenomatoid hyperplasia is a rare benign lesion that can be mistakenly diagnosed as other types of salivary gland neoplasm. Mucoepidermoid carcinoma and adenoid cystic carcinoma are the most common malignant tumors. Hemangioma. They are rarely seen in the hard palate. They are benign proliferation of blood vessels that primarily develop during childhood. They are the most common tumors of vascular origin of the head and neck region. Lymphangioma. They are malformations of the lymphatic system characterized by lesions that are thin-walled cysts, clinically present as soft, painless swelling, compressible of oral mucosa. Several investigations are carried out in order to reach for the final diagnosis. First investigation that was done was a maxillary occlusal radiograph. It was done to rule out erosion of underlying bone. The radiograph failed to reveal any underlying bony abnormalities. Minor salivary gland tumors. The palate is the most frequent site for minor gland tumors. Pleomorphic adenoma is the most common benign tumor, while adenomatoid. Under the microscope, there was normal salivary lobules, some showing hyperplasia, and dilated ducts with mild chronic inflammatory infiltrates. Based on the above features, a final diagnosis of adenomatoid hyperplasia of the palate was arrived at. So now let's talk about adenomatoid hyperplasia in details. Clinical features. Clinically, adenomatoid hyperplasia appears as a sessile nodular lesion, most commonly occurring on the hard and soft palate. Some uncommon locations include lower labial mucosa, retromolar pad area, buccal mucosa, and the tongue. The lesion is mostly asymptomatic, but occasionally may be painful. The lesion may be present for a few months or years, but most often is routinely discovered by a clinician. Since rarely patients will notice the lesion, or they may report only slow enlargement. Adenomatoid hyperplasia may vary in size from a few millimeters to larger lesions up to or over 3 centimeters. The mucosa over it will be intact and has been said to be of normal color, while some authors have reported the mucosa to be slightly red or bluish. On palpation, adenomatoid hyperplasia will be firm and non-tender. The etiology of adenomatoid hyperplasia is unclear. Various factors include idiopathic, local trauma, chronic irritation, denture, and smoking. The available literature suggests that adenomatoid hyperplasia is common in the 4th through 6th decade of life, with a wide age range. Male predominance has been noted, and Caucasians seem to be affected more. Management. Most often, excisional biopsy is therapeutic, and no special management protocol would be necessary. The lesion generally does not recur, and there are no reports of malignant transformation.